Welcome to On Becoming a Healer. I'm Stefan Kertes. Here's the very first sentence of a brand new book on the state of modern medicine. It says, medicine is losing its soul by dismissing mental health care and other psychological and social dimensions of its patients and by ignoring the very features that make us human. This new book is by Dr. Robert C. Smith. His book is titled, Has Medicine Lost Its Mind? Why Our Mental Health System is Failing Us and What Should Be Done to Cure It. We're going to dig into this argument and his recommendations with him as a guest. But before I go any further, let me turn to my co-host, Dr. Saul Weiner. Hi, Saul.
Hi, Stefan.
So why might the topic of Dr. Smith's book matter to us and to our listeners?
Well, I think it's a really important topic. It's certainly one that we've touched on in a number of other conversations. One of the things that I've faced as a clinician educator is just this, what I've called efficient task completer mindset, where I'm with a resident and they're doing a great job in terms of identifying the clinical issues, presenting the patient in an efficient way, and putting in orders, generating a note. And then so often what I get a sense of when I walk into the patient's room is that there's a whole story there. There's a person there. There's a set of emotions there that have just kind of been pushed to the back. And that they're often so critical, missed, that there's been some sort of failure of connection. And that so much of what is going to be important to a meaningful interaction and an effective care plan requires that kind of connection. So I've struggled with this. It's something that I've struggled with as a teacher of medicine. And it's something that I've found critical to my own growth as a physician, is having these connections and learning to do this in a way that's meaningful. So I really share Dr. Smith's concern about this topic. Reading his book, one of the fun things about it is I wasn't sure I agreed with a lot of his solutions. On the other hand, I'm not sure I have solutions either. So I think this is going to be it's going to be an interesting conversation. I do just want to comment on the fact that I think that today practicing medicine is incredibly challenging because, first of all, there are massive documentation requirements. I just saw a recent study, and there's one of these studies comes out every few years, that 73% of a resident's time is not patient facing. The amount of time they actually have with their patients directly is about 17.9% in the latest study.
Oh, God.
And it's just
That's
it's
horrible.
really kind of demoralizing to think about that, and certainly to experience it. I also don't think that there was any golden era in medicine. We did an episode recently on, as you know, a physician from the turn of the century, not this
20th
century, but
century.
last century. Yeah, 20th century. And we're actually now doing a deep dive into the prior century for an upcoming episode we're going to be doing. And like I said, each era has had its challenges. And so I don't think this is necessarily something that's just a new issue. And then I think the last thing I just want to say is that when I talk to medical students these days, and also residents, I don't get a sense that they are craving medicine as a vocation, as a calling. It's a job. So anyway, I think with this sort of big picture, I'm eager to dive into this and get some of Bob's thoughts. I'm looking forward to it.
So let me introduce our guest. Dr. Robert C. Smith is a physician in internal medicine with deep expertise in mental health and patient-centered medical care. He's the author of this brand new book I just mentioned, Has Medicine Lost Its Mind?, published by Prometheus. By way of background, he is a university distinguished professor of medicine and psychiatry at Michigan State University. He's authored books on patient-centered interviewing and on psychiatry in primary care. I mentioned the opening sentence of his book, and it continues to underscore that we fail to attend to the psychological and social dimensions of patients and undermine the care that we deliver. And it's that claim, the story behind that claim, and Dr. Smith's recommendations to improve matters that are going to be key to our discussion today. So welcome, Dr. Smith. Can I call you Bob?
Sure, Stefan. Thanks for having me. I'm looking forward to it.
So I'm going to start with a few questions. Your book has the word mental health system on the cover, but I really think you're aiming for something broader than just the mental health care system. So how broad is the problem you're asking us to fix?
Yeah. The problem is not just mental health, as you point out. It's all psychosocial, emotional material. A subset of that is mental health, but it goes beyond just mental health. And that gets into issues like communication, doctor-patient relationship, empathy, and all of the issues like that, addressing lifestyle issues of patients, which are mostly psychosocial. So it's not just mental health. Mental health is a prominent problem, and that's why I focused on that. There's a mental health crisis, and it's getting worse. but there is more to it than just mental health, as you're pointing out. Chronic physical disease, for example, is terribly mistreated for lack of understanding of the co-occurring psychological social issues.
That makes sense, and I do understand how it can extend beyond that. One of the things that I recall from your book is a story that I want to introduce because it seemed to be central to part of how you ultimately came to think that you had some learning to do. In the story, you describe a woman named April. She was relatively new to your city. She was 40 years old. And she was a sophisticated individual who had cancer. Lots of treatments had failed, and there really wasn't any other treatment yet to go. And as you engaged with her, you yourself felt anxious and fearful at times while you were trying to talk with her. She was often asking you how she could get better. What could she do to avoid getting worse? Why was she getting worse? And you described not really being able to say very much or even knowing what to say. And then finally, after her death, her husband came by your office and apparently spoke briefly with somebody up front and left a portion of her diary with you.
Sure.
April's journal has many comments about you. And then it says about you, now that there's no other treatment, the young doctor doesn't seem to know what to do with me. He just orders more tests. So depressed, so alone. Why doesn't he understand? That would help. I don't think he cares. And you read more along those lines, and you apparently had a pretty strong reaction. I was wondering if you could talk just a bit about how this affected you and affected what you did next.
Sure. That was a turning point for me. And I don't mean to imply that it was one of these rapid turnarounds, but it's what prompted a turnaround that then took place over 6 or 7 years. I had trained in a tertiary institution, knew all the differential diagnoses, like all internists do. When I went into practice, and I was about 30, as soon as I got into practice, there was stuff coming in my office that I hadn't a clue what to do with it. It would be people with psychological, social issues, stress, and so on. But April is the one that crystallized this. Yeah, what was happening in her note is exactly what I was doing. And there must have been 10, 12 visits I had with her before she died. So that really hit me to the core. I could hardly see patients the rest of that day.
Oh, God.
My mind kept going back to her, and she had this kind of feeble handwriting that was apparent in the notes that her husband left, and kept going back that my stomach got upset. I never had upset stomachs. And that went on for 2 or 3 days, and it just hit me. What am I doing here with a woman that would say something like that about me? I'm a doctor, and look how I have failed her. Absolute abject failure. So I kind of internally resolved at that time, well, I need to listen better. Maybe I need to
Okay.
talk more to people. And I actually started doing that. This is not some light going off in my mind and a dramatic turnaround, but that was the start of it. I started listening a little better, talking to people, hearing what they had to say. I found I liked that better. It seemed to help. People would say, gosh, you're the first doctor that's really listened to me this well, and I kind of like that too. I was getting compliments. And so this is over 6 or 7 years, but within that space, I would see chronic pain patients, and I didn't have a clue what to do with them. And the alcoholics, I have no clue of what to do with them. And so that was my transition and my recognition that I needed to know if I was going to really take care of people, not just to be a nice guy, but I needed some skills. And that's when I then went back to University of Rochester.
Yeah. So why University of Rochester? It has a little bit of reputation, but our listeners might not know it.
Sure. That consulted an old chief of medicine of mine. He knew about it, and I was describing to him, I was interested in these psychological dimensions of medicine and the social aspects. But how is there training in this anywhere? I didn't know anything about it. And he said, yeah, I knew this guy that he'd worked with once named George Engel at the University of Rochester. And he and another of my old chiefs of medicine during residency made contact with Engel and wrote letters for me. And then Engel invited me to come out there. Now, I was in a private practice at that time, making more money than I make today. And so it meant sacrificing all of that. And I then went out there. Rochester as you guys know, but maybe your listeners don't, was the mecca of so-called biopsychosocial medicine. Engel, 1977, wrote the famous paper in Science, the biopsychosocial model, and it has gotten a lot of play since then, although mostly lip service, unfortunately. But that's where I went back. And I then, as part of the fellowship, took inpatient psychiatry training. I learned psychotherapy, as well as this is where I was introduced to interviewing
As a skill set.
as a skill set. And also, I was in psychoanalysis for 4 years while
Wow.
I was there in Rochester. It's learning self awareness. And one of the issues that I think is very important, what we're talking about today, and it gets at what Saul was talking about earlier, one has to have an internal self awareness and a corresponding attitude that values patience. You have to be able to relinquish some control. You have to be able to be empathic. You have to be able to hear stories of death. And people not trained in psychosocial medicine have what they call countertransference. I
Oh,
mean,
what's that?
it's our own unrecognized feelings, our emotions internally that we have toward patients, but they're often unrecognized. For example, one of them I had was alcoholics. They said, well, in effect, my mind was saying, pull yourself up by the boots, get going, just stop drinking. It's that simple. Well, there's alcoholism in my family, and so on. There are dynamics that you need to understand about yourself to allow you even to enter into that. Death is another common theme. Doctors don't like it. I mean,
Surprise,
we're
huh?
surprised. We're all vulnerable. We're all going to die. I was teaching a psychiatrist one day, seeing a patient who kept saying he had bad emphysema. When am I going to do when I can't function anymore? He said, oh, you're going to get better. You're going to do fine.
That doesn't sound
Couple,
right.
this is a psychiatrist now interviewing him and saying this. I'm supervising the psychiatrist. And so the psychiatrist kept going, you do fine. And this went on like this. I then afterwards, and this is the first thing you do in debriefing someone on an interview. It's not how well they did the interview, the skills. It's how they felt about it themselves. And in talking to him, what came out was slowly, I'd say, so how'd that interview go? Pretty good. And I said, well, I noticed he was mentioning death and you kind of moved away from it. No, maybe I did. Now, and then we played the tape back. And he listened. Oh, I guess I did. He said, I really haven't been feeling good in the last year. My brother died of Hodgkin's disease last year. And it was really
God.
painful for me. And talking to his patient about death simply raised his own anxieties. And so I helped him then over the next several months to this awareness about death in his family. This is countertransference. It's easier understood as our own typically negative, unrecognized feelings about patients. They can, however, be positive. A lot of us have really good, caring feelings, but they've been taught don't get too close. And so we don't express them. In other words, I have positive feelings about a patient,
They
but I
could
don't
help.
express it. I don't say, well, let's work on that together. You and I can work this out. I don't say that because I've been taught to suppress those feelings.
Sure.
And so it's just this whole issue, Stefan, of so-called personal awareness, self-awareness. Anybody in the healing professions, we are exposed to so much difficulties in patients, and they express them to us. Much of that stuff is very stressful, especially mental health issues. Now, when you talk to people, many of them are depressed. They'll tell you, I don't know what to do with that. And so my negative reaction to that is not to explore it. I don't want to unearth something I don't know what to do with it. That's lack of self-awareness. And that is probably even more fundamental to training than learning skills. I can teach people the skills to do patient-centered interviewing. The issue is not whether they then demonstrate them to me. It's what they do when they're in the clinic and I'm not there with them. That is not a skills issue. That is an attitudinal issue. And so this is a whole area of training, and it is particularly important in mental health care
I want to ask, in your book, this comes up pretty strongly, but you do put it in the context of a broader indictment of our healthcare system that you think we're not doing the right thing more broadly. Now, part of it is indeed related to how we are trained, but I don't think your book is only about the shortfalls in the management of our internal distress as clinicians, but rather about the shortfalls of a system of healthcare, one where we're supposed to be doing great work with great technology and somehow we don't. Do you want to lay out a little bit of that broader critique of what healthcare is in the United States today?
Yeah, even though mental health problems are the most common health condition in the US, medicine trains only 2% of time in this for the most common health condition. And so, what's happening then is we go through 4 years of medical school, 3 to 5 years of residency, hearing nothing but physical disease. We don't hear about psychosocial issues. Medicine is training, as I said, only 2% of total time through all of that is devoted to psychosocial and mental health issues. And that has not changed, Stefan, since the Flexner report in 1910. That's over 100 years. Medicine is analogous to the fish that knows nothing but water. Medicine knows nothing but physical disease. And
Do you
it's
think?
a sad commentary because understanding the psychological and social and mental health aspects that medicine excludes is central to caring for the most common health conditions we see.
I would say that there was at least some effort to impart awareness of the biopsychosocial model, which you referenced earlier, to me
Sure.
in my medical school years in the 1990s. I don't think it came up in residency, by the way. So I'm
Yeah.
just talking about a few years of medical school, or maybe I read a paper or two.
Yeah.
Well, would you say the same?
Yeah, I mean, I think in the most recent training of physicians in medical school, there's now, at least in the last few years, there's been a lot of emphasis on teaching about social determinants of health, and I think there is perhaps more emphasis on thinking about management of a variety of mental health issues, including alcohol use disorder and so forth. I think there's been a lot more of that, but I think that whether it actually has any staying power is another matter. I think, for
Yeah.
example, you take all these classes, you hear about SDOH, social determinants, but then it's pretty much gone once you're working with these doctors in the clinical setting for the most
Yeah.
part.
That's what I'm kind of struggling with. So a little bit of exposure happens in the early years of medical school. Maybe we see something. I do feel like I've certainly a subset of doctors get really interested in addiction. I've seen that group because
Yeah.
they seek me out. But it's not the mainstream and it's not where the money is made. And I guess
Yeah.
I'm going to ask what stands in the way of the mainstreaming of this awareness, interest, and care for patients' psychological, mental, social dimensions of their lives? What's getting in the way?
Just to comment briefly, because biopsychosocial is probably in every school's mission statement. There's
Yeah.
no question. And you hear about it in medical school and so on. But even with that, it's been just lip service. Training time in mental health is not improved. Training and interviewing has improved. Since I went, I got no training in interviewing. Now, virtually every school in the country does, but it's never reinforced after that. And you have to learn skills. That means you have to be supervised by somebody that knows what they're doing, and
Wow.
that in turn implies that that person is able to work with you to work on your personal awareness to the extent that you can even use the skill. You can look at this on the positive side. I would not emphasize this much, but medicine has made progress. Biopsychosocial is a term people recognize, but medicine is simply tinkering at the margins in medical education by doing those things. It has not come close to effective training for mental illness, psychosocial, emotional factors, empathy, lifestyle factors. It doesn't come close to that.
I mean, we've kind of alluded to how to more than one possible impediment to this, but I mean, in your ideal world, let's say I have infinite money and run a medical school or I run a residency, what would you want me to demand to be done?
Train all students to be as competent in mental health and psychosocial, relational, empathic, lifestyle skills as they are with diabetes, cancer, and heart disease. And that's going to require going from about 2% of training time up to about 25% of training time. There has to be training in this every year of medical school And in the clinical years and in residency, you don't learn mental health going to inpatient psychiatry. You learn it in your usual clinical setting. And there have to be trained people there to supervise your
I have to watch.
and watch. And it has to be integrated with diabetes and cancer and heart disease.
When I think about my own clinic where I precept, there's a ratio of, I guess, 4 to 1 or something. So 4 residents to 1 faculty member,
Yeah.
some mandated number. And we're all kind of sitting in the back room and people come in and tell us about their patients kind of quickly. And occasionally we go over and say hi to the patient. It's more of a hail fellow, well met. Do you like the resident? Was
Yep.
it a good job? And that's it. Now, in order to actually observe an interview, I guess we would need to allocate more time from the teachers. More people might need to be assigned to go in and watch how care is occurring. Wouldn't that be necessary?
Of course. Yes, yes, yes. And we set one of these clinics up at Michigan State where we could sit in the room you're talking about, and through a video system, we could watch the interaction. But even antecedent to that, Stefan, the doctors doing that need to be trained and skilled
Yeah.
in psychosocial medicine. So the issue is we need to get trained teachers doing this.
I think we have to allude then to the history that kind of got us to this point. You go all the way back to Hippocrates and Galen in your book, and I suspect we can't do all of them justice. But your argument, at least, that there was a fundamental division between mind and body that played a key and anchoring role in medicine that drew some of its impetus from Rene Descartes, who identified that division. Could you say a little bit more about what Descartes did and why you think it really had impact on what medicine is today?
Sure. We've talked just before this about this isolated focus on physical disease. That began in the 16th century scientific revolution. And it actually began a century before Descartes in the then most basic science, human anatomy. Up until that point, and as you and I, we've all done this, we've dissected cadavers. You have to dissect a human body to understand it. And well, the Catholic Church at that time had prohibited that for over a millennium. But in 1537, Pope Clement said, okay, for teaching purposes, you can dissect the human body. But there's one proviso. The head must be removed from the body and turned over to church authorities before any dissection begins. The head is the source of the mind, the soul, and the spirit. That's our baby. You
My
guys
goodness.
get the body from the neck down. Then comes Descartes a century later, who provided the greatest impetus for this. This was the philosophical impetus, the final nail in the coffin that split the mind and again off to the church, the body to medicine and science. Now, some say that that was a grand compromise with the all-powerful Catholic Church that, okay, you guys get the spirit and the soul and the mind. We'll take the body from here down. In any event, Stefan, clinical medicine began adopting it in France in the early 1800s, and then it spread to the US in the early 1900s. And then what established the mind-body split isolated physical disease approach into U.S. medicine.
Yes.
It is important to underscore this all sounds critical of physical disease medicine.
Yeah, it does.
Physical disease medicine and the influence of Descartes were one of the most productive events in scientific history. In the 20th century, the 1900s, this isolated focus on physical disease was highly successful. There is no question about that. Ether, chloroform, sulfas, later statins, beta blockers, and now we've got GLP-1 agonists and fMRIs and genetics and all this and organ transplants. No question it's been successful. But medicine is conceptually arrested. It needs to adopt a systems approach. Biopsychosocial approach is another term for it. And if it does, it will get benefits equivalent to what happened in physics and other sciences. Mental health care, chronic physical disease care, financial savings. All of that is possible. Theory drives behavior. Most people now think of science as just randomized controlled trials and cohorts. Well, that just describes how to go about it. Theory tells you what to focus on, what to focus the science on. And so mind body theory says focus just on physical diseases. And that's exactly what medicine does. Medicine knows of this carnage, but they're tinkering at the margins. They need to go to the core theory that drives medicine, and that is a systems approach.
I should say emotionally, there's part of me that is jumping up and down saying, I want to see a new world that goes in your direction. And there's a part of me that is thinking, this is unrealistic and it won't work.
Yeah.
So, what would you want to ask or offer here?
Yeah, so a few things. So first of all, going back to this whole mind body split, as I said at the beginning, I don't think there was ever a golden age. And I think if you look back to the millennia before, there was an extraordinarily
Mm.
negative view towards mental health. People were burned at the stake. They were exorcisms. They were considered to be possessed by the devil. It was not a pretty time to have mental illness before Descartes either. No golden age. And I think some of our listeners, hearing what you're saying about this lack of teaching around mental illness and psychosocial issues, might be saying, well, wait a second, that's not true at my medical school. We really do teach a lot of that stuff. We really have done more of this teaching in recent years. And I would say, okay, maybe that's true, but where I would actually agree with you is I'm not sure it's actually paying off. I think that medical students may get a wide range of training experiences, and a lot of it just seems to peter out during residency. And I think it's important to start to think about the way in which the larger economic system is making that so difficult. You talked about how theory drives practice, and I'm going to say money drives practice. I think that what's happened right now is we're just in this environment that's just this industrial machine, and medical schools are part of it. I think you might ask yourself, why is it that there's not much more focus on the biopsychosocial model? I think it may be because it's not ultimately the economic model that is going to be the best benefit of a system which is about making lots of money for lots of people. And I think medical schools are just very much a part of that economic system. If you're a dean of a medical school, you're always thinking about ways of how do I bring in more revenue and how do I make sure that our practice plan is productive. And so you're, obviously maximizing the time that your faculty are spending seeing patients. You're trying to, balance that with making sure you're accredited by the LCME. You're in this environment which is not at all conducive to saying how do we actually create an educational model built around the biopsychosocial model that isn't just around the margins. And also the same thing with social determinants of health. Let's make sure it's in there, but ultimately we want to make sure a lot of our graduates go to internal medicine and then cardiology and then radiology. Medical students are coming through for that process. And then also, we don't come from a culture where people are very comfortable engaging. And so, our medical students are a product of that culture, and they come in and being with somebody who is suffering, who is dying, who's frightened, who's anxious, who's in pain, who's embarrassed. Those are things that our medical students and our residents are not well equipped to be present for based on the entire life experience they've had. And so I
Yeah.
think that the idea that we can tackle this with just kind of a change to the curriculum, I'm kind of a mixed mind of that. Yes, I do think that if we spent 25% of our time really focusing on these issues, it could have a huge impact. But I also skeptical that we would do it well. And I think that because there'd be so many pressures pushing in a different direction. And I think that a
Mm.
lot of times the teachers themselves, it would be very hard to train because to get people who are truly present and comfortable and then can convey that and can mentor that is those people are hard to find, and it's very hard in this environment where ultimately everyone's like, I got to study for that USMLE exam to really create a space for that.
Mm.
And so that those are some of the challenges. The other thing I'll mention is you've talked a lot about mental health as something that we're under addressing, but I think also it's important to say that we're also under addressing an acknowledgement of the poverty and the social conditions and the exploitation that so many people who have mental health problems have as a result of the exploitation that they experience in a society where they're underpaid, where they have to carry
Yeah.
two or three jobs, where they're not getting childcare, and that physicians are often just not really necessarily aware of that, or that it doesn't become part of the way in which they work with their patients. And so all of these are sort of things that are swirling around in my mind as I
Sure.
react with a certain amount of shared concern with you, but also some skepticism
Yeah.
about whether the solution is possible and whether it can happen in the way that you describe.
Yeah. I mean, a couple things. You raised a lot of issues, Saul. First off, I agree with almost everything you said, but I disagree with one thing. Our deans and heads of the American College of Physicians and heads of the AMA don't control medicine anymore. Doctors have lost control of medicine. It's now in the hands of the medical industrial complex.
Well, I
And
agree with
sure,
you, but let me just clarify one thing. I'm actually going to agree with you, but I'm going to qualify that. I think that what the deans have learned is that they want to keep their job. They have to make sure that they pay attention to the budget. And to do that,
yeah.
they are in turn beholden to the larger forces that you just described. So I'm not disagreeing with you. I'm just putting that in there
Yeah,
as a kind of
yeah. But I mean,
qualifier.
medicine is run off the rails because its medical industrial complex now is running itself. I think we need to call a spade a spade. What we've got right now is not going to change of its own accord. We are not going to convince medicine, or certainly the medical industrial complex. You go to the public. The public, you guys have all heard of the Flexner report.
From the early 20th century, this is the report that changed medical education and led to several schools being closed and others, which
You
had
got
more systematic curricula being upheld.
We need a new Flexner report to root out non scientific training in U.S. medical schools. And you've already heard how it is not using a systems biopsychosocial approach. When the public hears that all medicine needs to do is change its teaching, they're going to go along with it. As part of the recommendations this group makes, will be to set up a federal board. It will be independent politically, and so this is what needs to happen. The public gets inflamed and things happen through our politicians. We need to quit trying to get medicine to change.
So all is just realistic.
You and I, we did an episode on how unhappy patients are with feeling like they're being gaslit by their doctors. And so there was widespread discontent among patients with the way they're often treated when they go to the doctor's office, and particularly women and people from marginalized groups. And so I think there's an awareness among patients that the quality of the relationship they have with their doctor is often troubled. They don't feel like they're being cared about, and they sometimes feel like they're being badgered. And so those issues are there. And the question, of course, is if you were to say to the public, which I'm trying to go with Bob's argument here, this is because of bad medical education, and you need to really crack down on the way in which doctors are being trained. It's so narrowly focused on biomedical issues. There's a certain logic to that. I think that the issue is how likely is that to actually happen and to play out that way. One of the things that struck me in recent years is the extent to which special interests are able to create a set of attitudes among the public that basically make it very difficult for them to organize and to act as a single body to bring about that kind of change. I think it's important to ask why hasn't it happened so far? As you know, right now we're in a situation in our country where there's a huge disconnect between the general public and the way in which our politicians behave and the way in which special interests drive decision making and how money is spent and how schools are organized. And so we are kind of stuck in this rut right now where our medical schools are deeply embedded in the medical industrial complex, and patients are also very much under the idea that they need high-tech medicine, that the best thing doctors can do is be super focused on providing them with the latest, most expensive, best treatments.
None of that will be lost. We'll still be just as biotech as we are right now.
Well, the problem is a lot of the biotech we do now is actually not really helping patients. There's an enormous amount of overuse and misuse of
And that will
procedures.
be corrected too.
Yeah, well, unfortunately, I mean, we did an episode on that included a discussion of how and we weren't picking on orthopedists, but on so many of the complex surgeries that are done in that specialty have actually been proven in sham randomized controlled trials to be ineffective, and yet the number of those surgeries continues to grow
To grow, yes.
despite the overwhelming evidence that they're not effective. And you see that a lot. And the public is very bought into this idea of wanting the latest, and they succumb to these things. They get these surgeries done, and ultimately they're putting themselves at great risk without evidence of benefit. I think that the system is it's such a monster in terms of being driven by procedures and profit. And the medical schools are so much a part of that, that the real question is can we fix this problem simply by sort of calling on the public, for a patient movement to organize around this and
Yeah.
push medical schools would be a wonderful thing. I find it hard to imagine that happening.
It's the only route to go is to the public. The medical industrial complex now wants absolutely no change because they're making tons of money now. They're the major impediment. The public is the only direction to go if you're going to change any
Yeah.
of this.
I do agree with you in a sense, But you think about the political climate we're in right now, which is so
Mm.
profoundly dysfunctional.
But the Vietnam War, the public got involved. The women's movement, the civil rights movement, the public is effective if it gets involved.
So the question is could we actually get the public to rise up and say, we want the biopsychosocial model in medical schools? Like they first have to understand what that is. They would have to, they'd have to realize that it's really important. They'd have to start organizing. And, I'm just curious, like, do you see that playing out? I mean, when our boys are going off and dying in Vietnam, it's pretty clear cut. Like,
So I want to highlight that the name of the game in influencing policy these days often depends on who can produce the most digestible and emotionally satisfactory narrative for social media. There is a significant component of the American public that is activated very much about health and has profound suspicion of the medical industrial complex. But they have, in fact, thrown a lot of their faith and a lot of their hope into elements of an administration that are discrediting vaccines or suggesting that, if you could just change the content of your drinking water to have less fluoride in it, it's whoever produces the narrative that can grab the most people.
That's correct. And that's why the message has to be spread. What will really get the public is when we get a federal commission to conduct an investigation of medical education and show that it is non scientific. And if that doesn't get somebody's attention, nothing will.
you keep referring to non-scientific. The thing that I see that troubles me when I work with residents is a lack of seeing the humanity in the person they're with and the patient and caring about them and caring for them. And so to me, that isn't so much of a scientific issue. It's really about the capacity to see the full humanity of people and to be genuinely able to care about them as a person and to elicit whatever's going on in their life, to understand that elderly man who's come into your
Yeah.
office, who is confused about his medications, who is on a scooter, who's complaining of severe back pain, who's on 12 medicines, that, just staring at the computer and going through your checklist, and figuring out, all right, so we need a social work consult, and when was your last flu shot? And, I think you didn't haven't had a colonoscopy, et cetera, et cetera. And being able to say, who is this person? Why are they struggling? Is there
Yeah.
anyone in their life who's helping them? This is what I see missing every day. And when that person expresses fear or anxiety that the doctor doesn't want to deal with it, they want to push it away. They have another patient waiting. They're more interested in getting through the checklist so they can write their note. I don't really see that as so much about the scientific failure of medicine. It's something that is profoundly difficult to correct because it's getting to the whole capacity of that person as a
Yeah.
doctor
Yeah.
to be present and to be and the whole nature of the way in which they've been trained. And I think it would
The-
be very hard and challenging to create a social movement where you explain that to the general public, given that that doctor or that medical student is themselves a product of a system that has shaped them in a way that creates this lack of ability to connect, to be present, to be human, and to care and to love
yeah.
for the person they're taking care of. And to me, that's the big question: is how do we fix that problem?
Yeah.
And that's the challenge that I think we face, at least in my view.
Yeah, doctors will be trained in not just the knowledge of interpersonal skills and not just the skills in interpersonal skills, but in the attitudes and thereby the counter transference that goes with them. When they learn this, these are the very factors that allow them to express the love they previously suppressed for their patients. Doctors trained in this new way will develop a new narrative, which will be just what you're talking about. Now, at a political level, you simply say, many of you are unhappy with your doctor patient relationships. This will dramatically turn those around.
I find that one of the challenges in our medical education culture is that it breaks down self-esteem. It's a somewhat unhealthy culture where it's a little bit
Yeah.
militaristic and also infantilizing of medical students. And so it sort of does the opposite of what you want to do if you wanted to create somebody who is comfortable with themselves, who
Yeah.
is willing to be fully present, who's willing to be vulnerable. It does really all the opposite things that you would want to do. On one hand, it's ironic because they've achieved so much. They've made it to medical school, they made it to residency, they passed all these hard exams, and yet the inside of them is often quite
The
hollowed out. They've been
analogy,
hollowed out, yes,
the
rather
old
than filled
analogy
in.
is to the abused person.
Yes, and
If you
exactly
treat
right.
students abusively, they will
Absolutely.
treat their patients abusively.
Exactly, and even if they don't treat them abusively, they will hold them at arm's length because they're not comfortable being vulnerable and present.
Yeah,
And what they've
yeah,
learned to do is to be very efficient and technical and focused. And so I think
yeah.
the challenge becomes, in order to create a medical education that is along the lines of what you're looking for, you'd also have to change the culture. You'd have to create an environment in which medical students are fully respected. They're seen as junior peers. They're not quote put in their place. They're valued as individuals, and
Uh,
that's
now
something else
that
that's so hard to change.
that will be part and parcel of it. The very first thing that will occur in training is just what you're addressing. It will be teaching the skills and also the attitudinal requirements, and there will become then a narrative within the medical schools that values that. Family medicine is an example where there's a kind of a different attitude. They
Yeah.
have mental health people in their clinics, in the residencies, and there's a different mentality. It's a different narrative that you hear in family medicine. And so it will be the starting thing that happens, Saul, just what you're talking about. In other words, they need to learn to treat the humanity of their patients, not just their physical disease.
I think what I share with you is a concern about the nature of the doctor patient relationship and the culture of medicine. And I also share with you the view that our medical education system needs an overhaul and that it should focus far more on biopsychosocial issues. I think where I differ, and again, I don't have easy solutions here, is I've come to appreciate, at least in my view over time, how much our medical profession is simply a part of the larger culture in which we live. And that I don't actually think there was a golden era. Say medicine has lost its mind. I'm not sure it ever had its mind. I think it's always been deeply a part of the culture. And I think that, power and power structures are very much part of our society. In this country, we know that so much is structured around power dynamics and class and caste and so forth. The medical profession is very much structured around power dynamics and money. And I think that one of the great challenges of being a physician is saying, look, there's something very special about being a doctor. You're there at people's worst moments. You're someone who needs to be deeply trusted. You're someone who people turn to in many ways when they need to get outside of that system and find somebody who really has their interests at heart and who is looking out for them. And I think what we can say right now is that is all too much not the case. It's all too uncommon. You can't be sure when you go to a doctor, you enter a healthcare system, that it really is committed to you and to your what's best for you. And so I think the real challenge is, how do we change that? The reality is that it's not easy because medicine is so embedded in the larger culture. And our culture is so unfortunately centered around these power structures and around money and profit. I do think that each of us as physicians and as educators can think hard about how can we make being a doctor really about being truly an advocate who steps outside of this monstrous system and puts that relationship first and says, that's how I'm going to live as a doctor. That's my oath. And then creating a culture within medical schools that tries to nurture that, but it can only nurture that if it treats its students and its learners with that same level of respect and caring. And again, that is currently, unfortunately, too rare. I had an opportunity to speak to some first year medical students who are just starting a few weeks ago. And just, I had this conversation with them about all the things that trouble me about the educational process that they're entering into and about the healthcare complex that they're then going to go into afterwards. And what struck me in the comments I got from them is that they just appreciated having the conversation. I didn't have answers for them, but they
Yeah,
appreciated that I was talking very candidly. I wasn't sending them the message, oh, you've made some big mistake. You should become a doctor. Not at all. I was saying, this is really the most important thing I think you can do with your life. But buyer beware. You're entering a system that is going to do so much that is harmful in terms of the way you're taught, the culture you're in, the way you're treated, and then ultimately
yes.
the system in which you enter. And I just want to share that with you so that you can start thinking about it and reflecting on it and thinking about how you're going to manage your own growth going through this somewhat
Yeah.
toxic process. So I didn't really have answers for them, but I did find that just being square with them, being honest, and having that conversation felt like a good place to start.
Yeah, yeah. What we're doing is not only not working, things will be worse in 10 years if this theoretical basis of medicine does not change. The public has to get involved. That's to me is hopeful. Now, having said that, there is a nidus of people who want the same things we do. There is a base there from which to spring once this change takes place.
Thank you so much, Dr. Robert C. Smith, author of Has Medicine Lost Its Mind?
Yeah, thanks.
Thank you.
We hope you've enjoyed this latest episode of On Becoming a Healer. If you have and you haven't already subscribed, please consider doing so now. Also, please rate us on the Apple Podcast app as it will help others find us. And if you have a few moments, leave a review. In addition, if you'd like to make a comment about this episode, we'd love to hear from you. There are a couple ways to do that. If you're using the Apple Podcast app, then just open the episode website link and enter your comment there. Or you can directly go to the website contextualizingcare.org, select the podcast tab, and then scroll down and click on the episode. There you'll find the same comment box. Finally, you can always reach us at onbecomingahealer@gmail.com.